Right, you've been told you've got osteoarthritis. What do you do? Let's find out. Hi guys, my name's Luke and I'm the practice owner and lead osteopath at Body Zest Osteopathic Health Centre. We treat tons of patients with osteoarthritis. It's very much our bread and butter, and we know lots of different ways to support them. So it's a really interesting topic because osteoarthritis is so common. Basically everyone to a certain degree will get osteoarthritis, but there's a kind of, oh my God, what is it? Is it a death sentence? Do I need a hip replacement? There's so many questions that are going to come up around arthritis that it's good just to be sure that everyone fully understands what to do when they get the diagnosis in the first place. So there's a couple of different scenarios which we have to play out to be able to answer the question of what do I do if I've been told I've got osteoarthritis. So the first one, just for a few kind of patient examples from my experience, the first one would be the patient that comes in, they've been told they've got osteoarthritis. Usually that is because they have had an X-ray. The X-ray is a nice, simple way to do that diagnosis, and you know, dependent on where people have pain and how long they've had pain for, GPs in the UK will typically just go for the X-ray just so they can decipher if this person has osteoarthritis. We'll call it OA if that's okay. Decide if they've got OA and what the severity is initially. So by the time people come to us, some of them would have had that X-ray, some of them wouldn't. Assuming you've had the X-ray, you've been told you've got osteoarthritis, then there's a few questions which we're going to ask to try and have a conversation about what's going on with it. Now, the first thing, if you haven't got access to the X-ray and then we're just kind of trying to jog your memory, is always going to be, do you remember if it was mild, moderate or severe? If you've got the X-ray, great. Some osteopaths will be able to actually, just look at the imaging. Others will just read the report. But we are really concerned about mild, moderate or severe osteoarthritis because there are so many factors to talk about, like your age and your symptoms, how much pain are you in and all the rest of it. But fundamentally, mild osteoarthritis is just the initial signs of a little bit of wear and tear. Moderate is, moderate, okay, things have started to change and we're starting to really see some reaction here. And severe is likely, including bone on bone and this kind of thing, that this is now not conducive with proper function and mobility. The reason this is so important is because there does seem to be a tendency for people to be told, okay, you've got arthritis, that explains why you've got pain in this certain area, and then they're kind of just told, well, that's part of aging. It's not bad enough to replace the joint, or it's not in an area where a joint replacement is a viable treatment option, so kind of bad luck, ride it out, see how you go. The reality is though that if that report says that you have got mild osteoarthritis, then mild osteoarthritis would be expected to be found in anybody over the age of, you could argue 40, maybe lower in certain cases if people have been really active, just some sign of, okay, mechanically this area has been working and there's a little bit of a difference there. It does not mean that you should be in pain. And I guess osteoarthritis in some ways isn't a diagnosis, it's a finding, because a diagnosis, in my opinion, has to incorporate what tissue is causing this person's symptoms, why is it happening in the first place, what's stopping it from recovering itself, what's maintaining this problem for this person, like why can't the body cope? And to just say that mild osteoarthritis is a diagnosis which incorporates all those elements is just not true. Severe osteoarthritis might be, because by the time something is severe, it's kind of maintaining itself. It's bone on bone. Why can't the body cope? Because it's bone on bone. But for mild osteoarthritis, and sometimes definitely moderate as well, then we'd say actually the body should be able to cope with this, because osteoarthritis is normal aging changes. It's what we expect to happen, and not everyone with osteoarthritis is in pain. So for that reason, you shouldn't just be able to say, okay, well, this person is going to have pain, just because they've got OA, because, well, everyone else with OA isn't in pain. So, the two don't add up. So basically, when we're looking at this, we're then saying, the person's saying, okay, I've been told I've got osteoarthritis. Then it's like, okay, if it is mild and the person has got a half decent level of fitness, then we should be saying, first question, in my opinion, why is the body not coping with this little bit of osteoarthritis? Or has the x-ray showed an incidental finding, and in fact there is OA at the site of the x-ray, which is at a similar site to another structure, which is actually the tissue which is causing the symptom. So let's go into those two things. So the first way of looking at it, why is the body not coping with the osteoarthritis, is commonly what I'd call caused by a compensation issue. And these are absolutely real and they absolutely happen. So I've had patients who, for example, have got knee pain. They've gone to the GP's x-rayed, they've said, you've got osteoarthritis. I've even had patients who have been told, offered a knee replacement at this point, but they've decided to look at non-invasive options like us first. Now, when we assess, you think, okay, the knee isn't stiff, the range of motion's good. Why is this person's body not dealing with this little bit of wear and tear? And that's when you can start to then say, okay, well, what is the hip doing? And what is the ankle doing? Because the knee really is just the point between those two areas. And what you might find in that situation, and what we absolutely have found treating patients here, is that if you optimize through the ankle that maybe is stiff from a historic sprain, or you optimize through the hip, which is potentially weak and needs to be strengthened, then fixing one of these other areas can take the load off the slightly arthritic knee joint, and then all of a sudden it stops being painful. So it was the osteoarthritis that was causing the pain, but it wasn't the osteoarthritis that was the whole diagnostic picture. There was something else which was leading to that knee overworking, and because it was slightly arthritic, it couldn't handle that little bit of increased load, and then it got painful. So that is not a reason to lop someone's knee out and put a new one in because you found some OA there. You can deal with it in a completely different way. And the other way of looking at it is the osteoarthritis an incidental finding, and have we got something else that's actually causing it? And this is really common with a bursitis. So a slightly arthritic hip, patient told, yeah, well, that's that. And, the x-ray has concluded that that's the problem. And then when you actually get in there, the hip doesn't move too badly. The hip isn't too stiff. But when you get someone to do anything actively, oh my God, it really hurts. Okay, so we know that the muscles are contracted, the tendons are then put on tension. They're what's causing the pain. You look into it and it's a hip bursitis. You treat the glutes, you strengthen, you shockwave, you do whatever you need to do to fix the bursitis, and the pain goes away. The hip is still mildly arthritic, but it was never actually the problem. It was just an incidental finding that turned up when an investigation was done into the pain area. So that's a couple of ways of looking at just sort of slightly milder x-ray findings for osteoarthritis. When we are going into moderate territory, then the lines get blurred, because you still could apply the principles of when we find a mild case, but you can then apply principles of when we find a more severe case, which we'll talk about now, what happens when there's actually a bit more severity there to your osteoarthritis diagnosis. The way that you want to look at it really always has to be reverse engineering your ideal outcome and what you want to get out of life and get out of this joint that has got arthritis. For a lot of people, they just do not want a hip replacement. Let's use a hip, for example, in this situation. So a lot of people, they'll get the diagnosis, they've got a really severe, osteoarthritic hip. If they're in lots of pain, a lot of people will say, can we try and manage the pain and just see if there is a way that I can live with this stiff hip for a bit longer, and then I will have my inevitable hip replacement in the future. For other people, they'll just say, I don't ever want one and I want to try and manage this situation. So the treatment that we're administering and the advice that we're giving is reverse engineering the outcome that they want, because we're not going to say to people that there is a right or wrong thing to do when you've got, osteoarthritic hip. It's up to you, what do you want to get out of it? That person isn't going to be able to do some of the things which other people do if they do get a hip replacement. And as long as they understand that and understand what their options are and what their limitations are, then it's, you know, an absolutely personal choice. There is no right or wrong. So in the case of this person, my advice is to always approach non-invasive first and make your way up the invasion scale. So non-invasive options, which are, you know, reducing the soft tissue tension and getting as much mobilization out of the joint as possible, and exercising and strengthening and doing all of these things which, you know, aren't going in there and changing anything about it. We're just improving what's already there. Then absolutely start in that point and see where you can get it to, and see if you can improve things up to a point that you think is manageable. With exercise, you might find that when you exercise it hurts, but all round, if you keep going, then it starts to make it feel a lot better. So sometimes you have to push through a little bit of pain to get an all right outcome, but there's nothing wrong with that. There's nothing wrong with that approach if that's the approach that you want to take. If you are more open to, you know, invasive surgery, then yeah, looking at, you know, injection therapies and stuff like that, you know, very strong anti-inflammatory injections like steroid injections can be really useful for just managing these kind of problems too. Again, I would say starting non-invasive makes more sense before you move on to something like that. And then lastly, you've got the actual, you know, joint replacement. For some joints partial, for some joints total. So you want to really be thinking about that end goal again, because when it comes to a joint replacement, you know, for a lot of people, if they're in really severe pain and they've already got bone on bone, then it can be something that absolutely improves their life drastically at an age where they should still be being mobile. You know, it's all well and good saying you need to put this off as long as possible, but you are more likely in your 60s to be getting out and doing stuff than you are in your 80s. So to say, well, I'm going to sit around in pain and not move in my 60s and into my 70s and then have this replaced in my 80s so that the shelf life doesn't run out before I do, it's not always the right way to look at it for people, because sometimes people are saying, no, right now I want to be active and right now I want to do the things that I want to do, and this, you know, joint replacement is going to facilitate that. So you always really be wanting to think about, what's it likely to get me to, and is this the right time for me to be able to do it? Another aspect of that is obviously the outcomes of things being better when we're younger. We have more resilience, we have more strength, we have the ability to bounce back better. And when you do these things at a slightly younger age, even though there is they might not last long enough and you might have to have it done again component, that isn't a blanket rule for everybody. For a lot of people, you know, joint replacements can last an incredibly long time nowadays, and they were really happy that they made the decision to do it when they were younger to get the best out of that situation. Right guys, I hope that helps with a little bit about what do I do when I've been told I've got osteoarthritis somewhere. Yeah, if you find these videos helpful, then subscribe, follow us across other social media, and if you're in the South London and Surrey area and you want another perspective on non-invasive management of osteoarthritis, then go to Body Zest, book an appointment, and we will see you there.